Picture this. In healthcare, the influence wielded by, say, the head of a department or a key leader, well, it can be exponentially greater than any single individual contributor.
Hmm.
It's a really powerful dynamic actually highlighted in the sources we're looking at today. It shows how leadership effectively scales impact.
For good or ill.
Exactly. Whether that impact is profoundly positive or, well, unfortunately, significantly detrimental. Welcome to the Deep Dive. This is the show where we take that stack of sources you've shared with us, cut through all the noise, and really distill the most important knowledge and actionable insights you need just to get you up to speed quickly.
Right.
Today, we are undertaking a deep dive into the absolutely critical and, let's face it, often complex world of healthcare leadership. We've got a fascinating collection of materials here. It covers, well, everything really,
Yeah.
from the unique historical path of leadership in nursing right through to the big challenges posed by organizational mergers, the specifics of quality improvement, and the particular context of leading academic health centers.
It's quite a range.
It is. It's a sprawling topic. And navigating it, well, it requires sharp analysis. So to help us make sense of it all, connect the dots, and explain why it all matters, I'm joined by Prof. Mo Imam. Your ability to synthesize diverse information is, frankly, exactly what this kind of deep dive calls for. So thank you for being here.
Oh, it's a pleasure. Thanks for having me. The sources you've shared, they really do provide a comprehensive view, almost panoramic, I'd say, of healthcare leadership, highlighting both those sort of enduring principles and also the really acute pressures of the current environment. It's definitely a vital area to explore.
It absolutely is. And before we sort of immerse ourselves in all the detail, let's get that high-level view, a bit of a rapid-fire setup based on the materials you've reviewed. So, Prof. Mo Imam, how do these sources specifically define or maybe distinguish leadership from management within this healthcare context? And crucially, why is making that distinction so vital, well, right now?
Yes, that's a great question. The sources are actually quite emphatic on this point, particularly management to leadership and lean leadership. They frame management as primarily about coping with complexity,
Yeah.
maintaining the present state, so focusing on systems, processes, planning, organizing, controlling, all within established structures.
Okay, sort of keeping the ship steady.
Precisely. Think about keeping operations running smoothly day to day. Leadership, though, is fundamentally about change. It's about setting direction, aligning people to a new reality, transforming the organization, and crucially, inspiring movement towards a defined future.
Yeah.
And this distinction, it's paramount because healthcare is currently undergoing such rapid, profound, and complex changes. Just relying solely on management to navigate this tidal wave of transformation, it just isn't sufficient.
Right.
It requires leadership to define that new course and, importantly, motivate people to actually follow it.
Okay, so management handles today's complexity, leadership tackles tomorrow's transformation. Got it. That makes sense. Now, across all these varied sources, and there are quite a few, what emerges as the single biggest, maybe the most recurring challenge for healthcare leaders?
That's a tricky one because so many of the challenges are interconnected, aren't they?
Mm-hmm.
However, I'd say a dominant persistent theme is the struggle with role conflict and burnout. It often seems to stem from a lack of clarity, maybe insufficient support, and that real difficulty of balancing clinical credibility with managerial demands. You see, leaders, particularly those coming from clinical backgrounds, they frequently find themselves with some immense responsibility,
Right.
but maybe limited formal authority or not enough time away from their core duties to actually do the leadership part.
Yeah, I can see that.
And they face resistance or misunderstanding from various stakeholders.
Yeah.
It all leads to, well, profound frustration and ultimately burnout.
That tension, the clash between the clinical role and the managerial demands, and the strain that results, that really does seem to cut across different parts of the sources, doesn't it?
It does, consistently.
Okay. And finally, for this quick setup, if you could just distill it down from everything you've read here, what's the one absolutely essential quality or maybe principle of successful healthcare leadership that these sources consistently underline?
Oh, without question, I think it has to be having a clear sense of mission and vision. Leaders must articulate a compelling true north, a defined purpose, and a really vivid picture of the desired future state. This vision, you see, it provides essential direction. It focuses effort, creates momentum, and aligns people. It gives meaning to their work, especially amidst the chaos of change.
Right.
And leaders have to be willing to, stake their reputation on guiding the organization towards that vision.
Defining that true north. That really feels foundational, doesn't it?
Excellent. Okay, that gives us a powerful framework for this deep dive. Let's now move into our first substantive segment. We could explore the landscape of healthcare leadership and those significant challenges in a bit more detail. We'll start right there, actually, by expanding on that crucial distinction you just made between leadership and management. As you mentioned, sources like Management to Leadership and the Bishop text, they paint a very clear picture. Management is depicted as the steady hand, dealing with the intricate systems, the processes of the present. It's coping with complexity.
Yes, exactly. Imagine, say, the operational challenge of managing a hospital with a consistently high patient census. A manager's focus would be on optimizing bed flow, staffing ratios, scheduling, ensuring supplies are available.
The nuts and bolts. Precisely. Essentially refining the existing processes to handle the load more efficiently. They are absolutely essential for stability and operational excellence, but within the current framework. The Management to Leadership source uses that example of Bligh before the mutiny on the Bounty, remember, focused intensely on strict adherence to procedure and order, maintaining the system.
Right, keeping the ship running strictly according to the book. But leadership is something else entirely, isn't it? It's not just about maintaining, it's about moving forward, often into, well, uncharted territory.
Spot on. Leadership is about questioning the established order, identifying where the organization needs to go in the future, and then mobilizing people to get there. It involves setting direction, defining a new strategy, creating alignment around that strategy, and, crucially, inspiring people to make it happen. Think of Bligh after the mutiny, as described in the Bishop source. Adrift in that open boat, his technical management skills were, frankly, useless. His survival depended entirely on his ability to define a seemingly impossible vision, reaching safety across thousands of miles, and inspiring a dispirited, broken crew to believe in that future and follow him. He had to build credibility through his actions and his conviction, not just through his title.
That transformation in Bligh,
Yeah.
from rigid manager to visionary leader under that extreme duress, that's a really powerful way to illustrate the difference. And as the sources point out, this capacity for leadership isn't just confined to those with the senior titles, is it?
No, exactly. The Bishop text notes that while managers often derive authority from their positional title, this can sometimes lead to a detachment from the frontline realities. Particularly for clinical professionals who move into management roles, the source colorfully describes this for nurses as sliding down the professional nurse snake in terms of losing clinical credibility among their peers. But true leaders, they can emerge from any level. Their influence is often based more on their clinical knowledge, their experience, their values, and their ability to inspire trust and commitment through their actions and communication, rather than just their formal role. As Bennis is quoted in the Lean Leadership source, leadership becomes particularly vital when the focus is on transforming organizations and orienting them towards the future.
So leadership is earned through credibility and vision, not just granted by position. Okay. Now let's layer in some of that historical context that shapes healthcare leadership today, particularly in fields like nursing, as the Bishop source delves into its peculiar history, as it calls it.
Indeed. The history of nursing leadership is, well, it's complex, initially rooted in tradition, superstition, religious practice, before becoming largely subsumed under the authority of a, frankly, male-dominated medical profession. The establishment of the NHS in the UK in 1948 brought significant changes, as did the subsequent Griffiths Report in the 1980s. That introduced more formal management structures and was intended in part to curb the sort of unchecked authority of doctors.
Right, I remember that.
However, the Bishop source argues this had an unintended consequence for nursing. It caused it to lose any illusion of the power it might have once possessed. Because that perceived power, it wasn't truly autonomous. It was more of a patriarchal one, gifted from medical colleagues. So when the structure shifted, that external source of power, well, it diminished.
That's a fascinating point, that reforms aimed at one power structure, medicine, could indirectly impact another profession, nursing, in such unexpected ways.
Absolutely. And we see similar dynamics actually in the U.S. healthcare system. The dominance of physicians is reinforced by rapid subspecialization and the structure of licensing boards, which often place other allied health professions like physical therapy, occupational therapy, even nursing under the formal supervision of physicians. The sources suggest that powerful professional elites, like medicine, can be particularly resistant to imposed change. Sometimes they adapt in ways that maintain their influence rather than truly empowering other groups. Such as, well, doctors moving into general manager roles after the Griffiths report, for instance. That could be seen as one such adaptation, couldn't it? Maintaining control through a different route.
So these historical structures and professional power dynamics are deeply embedded, and they influence the landscape leaders operate within today. This leads us directly into the major challenges that healthcare leaders are facing now. What are the most pressing issues highlighted across these sources?
Well, one of the most palpable challenges vividly described in Management to Leadership is the sheer relentless crush of change. Healthcare isn't just incrementally evolving, it's undergoing radical transformation. We're seeing huge shifts in where care is delivered outpatient home care. The rise of niche hospitals focused on specific procedures, the integration of distance medicine, internet-based healthcare, automation taking over tasks, increasing outsourcing, cross-training initiatives, complex partnerships, and of course frequent mergers and acquisitions. This constant disruptive flux means leaders can't just refine existing operations. They have to continually navigate and lead adaptation to fundamentally new models. It's exhausting.
That speed and depth of change must create immense pressure. And it links directly back to that challenge of role conflict and burnout we touched on earlier, doesn't it?
It does.
The Bishop source gives that specific example of ward sisters or managers in nursing. They feel their traditional clinical role is diminishing, yet they often feel ill-prepared for the increasing demands of leadership, quality improvement, managing complex teams.
Exactly. They're caught between worlds, aren't they? Leading to feelings of isolation and being pulled in too many directions. And that specific case study in Bishop resonates really strongly with the broader theme in leadership lessons. You see healthcare leaders across different professions, like a medical leader profile there, they often grapple with this profound imbalance, significantly more responsibility than formal authority to actually enact change.
Right, the power gap.
Yes, coupled with insufficient protected time away from their primary clinical or technical duties to actually do the leadership work required. This leads to deep frustration because they're held accountable for outcomes they feel powerless to fully influence. And ultimately, yes, to burnout. As one quote bluntly puts it, you don't take on these demanding roles to make friends.
That lack of time, lack of formal authority combined with immense responsibility. Yeah, that sounds like a recipe for stress and disillusionment. Beyond these internal struggles, the sources also point to difficulties in influencing the external environment, specifically influencing policy.
Yes.
Despite decades of effort by professional bodies like the International Council of Nurses, ICN, or the UK's Royal College of Nursing, RCN, nurses, for instance, still face significant hurdles in accessing and shaping local, national, and even international political agendas.
That's right. The Bishop source examines this through the lens of the RCN Political Leadership Program evaluation. It highlights that while there's recognition of the need for nurses to engage politically, translating that clinical expertise and experience into effective policy influence is, well, it's challenging. Jenny's case study in that source detailing the really arduous process of establishing national guidelines for non-medical practitioners to request x-rays, it's a powerful illustration of the sustained effort required.
What did that involve?
Oh, evidence gathering, coalition building across different professional groups, persistent lobbying. It's a long game. Programs like these, they aim to demystify the policymaking process and build the confidence and skills needed to engage effectively.
So there's a clear understanding that policy influences practice profoundly, but the path to actually having influence is steep and requires specific development. Understood. What about cultural challenges within healthcare organizations? The sources seem to touch upon a few different aspects there, too.
Yes, definitely. In settings like academic health centers, AHCs, the source specifically on AHCs points out that their traditional structure, often organized into powerful, autonomous academic departments, actively inhibits enterprise-wide management and the seamless sharing of knowledge.
Silos.
Exactly. Each department can operate as its own silo, making integrated leadership and resource management really difficult. And then the merger source adds another layer. It explains that during periods of major organizational change, like mergers, companies tend to become intensely inward-focused.
Right, navel-gazing almost.
Kind of. And this can lead to neglecting vital external relationships with customers, patients, partners, the wider community, essentially creating what the source calls a terra incognita of forgotten stakeholders.
That inward focus during turbulent times seems particularly risky in healthcare, doesn't it? Where those external relationships with patients, communities, other providers are so absolutely critical.
It's very risky.
And speaking of patient interactions, the sources even highlight challenges stemming from difficult patient encounters themselves.
Indeed, yes. The public health source includes an example related to cardiac rehab that mentions navigating hostile communications from patients' families. While perhaps a different category than systemic challenges, it does underscore the emotionally demanding environment healthcare leaders and staff operate in. It requires really strong interpersonal and conflict resolution skills.
That's a good reminder that leadership isn't just about strategy and structure, it's deeply, deeply human. Finally, the Academic Health Center source raises a critical challenge regarding knowledge management. Despite being institutions where knowledge generation and application are absolutely central through research, education, clinical care, AHCs often struggle with knowledge being piecemeal, ad hoc, difficult to capture systemically, or effectively transferred across different domains.
It's quite striking, isn't it? This contrasts sharply with how other industries strategically manage and leverage their core knowledge assets.
How so?
Well, the knowledge is created and exists in abundance within an AHC, but it's often trapped within specific departments or individuals. It's not flowing freely or being systematically applied for broader organizational learning, strategic decision-making, or process improvement across the entire institution. Those traditional siloed structures really seem to impede effective knowledge capture and transfer.
Okay, so the landscape is incredibly demanding. Navigating rapid transformation, overcoming historical power dynamics, alleviating burnout from complex roles, influencing policy in a challenging political environment, breaking down internal silos, maintaining external focus during change, handling difficult human interactions, and effectively managing the very knowledge that is healthcare's foundation.
Wow.
It makes the task of effective leadership feel almost overwhelming.
It really does. The leadership by example source, in discussing the difficulty of driving quality improvement, uses a powerful analogy. It suggests that some healthcare reforms are merely tinkering with a Model T Ford,
Right.
when what is truly needed is a fundamental rethinking, a fundamentally new approach, more akin to designing a modern vehicle from scratch.
Some healthcare reforms are merely tinkering with a Model T Ford when what is truly needed is a fundamental rethinking, a fundamentally new approach. That really lands.
And bringing it back to clinical leadership, the Bishop's source highlights that ethos gap, that inherent tension between the clinical professional's focus on individual patient care and the broader population level or managerial demands of leadership roles. Closing that gap requires specific skills and understanding.
That ethos gap seems central to so many of the challenges we've discussed, particularly role conflict and burnout. Okay, we've painted a really detailed picture of the landscape and the significant hurdles healthcare leaders face. Now let's shift our focus. Let's look at the strategies, the context, and the development needed to successfully navigate this complex environment. Welcome back to the deep dive. Having explored the challenging landscape of healthcare leadership and the significant hurdles it presents, let's now turn our attention to what the sources tell us about effective strategies, how leadership applies in specific contexts, and what's needed to develop future leaders. Based on your review, Prof. Moyamam, what core principles and strategies are highlighted as essential for navigating this environment successfully?
Well, several key principles really stand out as crucial foundations for effective leadership. As we touched upon earlier, the first is having a clear and compelling vision, mission, and purpose. The management to leadership and lean leadership sources really underscore this. A well-defined mission provides direction. It focuses the organization's energy. A leader's vision isn't just some static goal. It's something dynamic that generates momentum, pulling people towards a shared desired future state.
Right.
Leaders must articulate this true north clearly and be prepared to visibly commit to guiding the organization towards it, effectively putting their own reputation on the line, as it were.
So leadership starts with knowing why you exist and where you're going, and being courageous enough to define and champion that future.
Okay, how do effective leaders get people to buy into that vision and mission then?
Well, primarily by focusing on building commitment and trust. The sources make a critical distinction here. Compliance follows rules, but commitment engages people's heart and emotions. It's about fostering genuine buy-in.
Not just ticking boxes. Exactly. Successful leaders achieve this by working in partnership with others, building connections, fostering a sense of community, clarifying shared values. When people understand and share the underlying values and purpose, it creates the possibility of a powerful, shared vision that is genuinely inspiring. And in the context of Lean leadership, trust is placed in people's inherent capability for development. Errors are seen primarily as issues with the system, not personal failures. That builds psychological safety and encourages continuous improvement.
Engaging hearts and minds, not just enforcing rules that sounds like the essence of building true commitment. And that surely requires exceptional communication skills.
Absolutely. Effective communication is presented as a vital strategy. Exemplary leaders are described as skilled translators.
Translators, how so?
Well, they're sensitive to nuances, capable of adapting their communication style based on their audience. They understand that some stakeholders need detailed data and extensive rationale, while others just require the concise bottom line. Tailoring the message ensures it is understood and resonates across different groups.
It's about making sure the message actually lands effectively for everyone, regardless of their preference. Makes sense. Thinking back to the challenges of implementing change, especially with those powerful professional groups we discussed, what strategies suggested there?
Ah, yes. The Bishop source suggests that in healthcare, where powerful professional leads hold significant influence, change is often more effectively implemented through empowerment rather than imposition. So rather than dictating solutions from above, empowering professional groups like nurses or physicians to identify problems and develop solutions themselves can lead to greater acceptance, more effective implementation,
And less resistance.
and avoid the counterproductive adaptations that can occur when policies are simply forced upon them. Yes.
Giving professionals agency in the change process leverages their expertise and reduces that resistance. Okay. Any other core principles for guiding behavior that stood out?
Yes. The management to leadership source highlights the critical importance of rewarding desired behavior. Leaders must clearly define the behaviors they want to encourage and ensure that these behaviors are consistently recognized and rewarded. Seems obvious, but
Please easily missed.
exactly. If desired actions are ignored, they will likely cease. And even worse, if unintended or counterproductive behaviors are inadvertently rewarded, well, that directly leads to poor outcomes and undermines the leader's objectives.
That seems so fundamental, yet probably often overlooked in the day-to-day pressures. And for leaders themselves, how do they continue to learn and adapt in this rapidly changing environment? What do the sources say?
Primarily through reflective practice. The sources emphasize that effective leaders are continuous learners, engaging in regular reflection, thinking critically about their experiences, their motivations, the outcomes of their decisions. What truly matters, it's a powerful tool for self-awareness and ongoing development. It allows leaders to learn not just from successes, but perhaps even more importantly, from difficult situations and perceived failures.
That commitment to self-learning through reflection seems absolutely vital for long-term effectiveness, doesn't it?
It really does.
Now, let's look at how these principles manifest in specific healthcare contexts. Let's start with lean leadership. The practical lean leadership source uses a case study approach to illustrate this, you mentioned.
Yes, the case study demonstrates the practical application of lean principles within healthcare settings and the specific demands it places on leaders. It draws on Benes core components of leadership, things like vision, passion, integrity, trust, curiosity, boldness, and shows how these are applied in a lean context. A key philosophical point is that servant leadership, where the leader supports the team and removes obstacles, is far more compatible with a lean culture than traditional directive management styles.
Okay, so less command and control.
Much less. Lean requires leaders to act as coaches, often using tools like the improvement kata, which Mike Rother describes as a structured, scientific routine for continuous improvement. Leaders must lead by example, not just talk about lean. They need to translate its abstract concepts into tangible, visible behaviors on the ground.
So, lean leadership is deeply practical, rooted in a specific philosophy, and requires leaders to be coaches and role models. Got it. What about leadership in quality improvement? The leadership by example source highlights the government's multifaceted role here.
Yes, the source outlines the government's significant roles as regulator, purchaser, provider, and research sponsor, all impacting quality enhancement efforts. A persistent challenge it notes is the standardization of quality performance measures. There's duplication across initiatives, conflicting methodologies for measurement, and often a lack of transparent, publicly available data.
So, how do we fix that?
Well, the report suggests that interdepartmental government structures like the QIC, that's the Quality Interagency Coordination Task Force, need to collaborate effectively with private sector bodies like the National Quality Forum, NQF in the U.S., which is a key organization for setting quality standards. The goal is to reach consensus on measures and avoid redundant efforts. But crucially, The source stresses the absolute need for integrated health information systems and widespread adoption of computerized clinical data to effectively track performance across different care settings.
And IT adoption has been patchy, hasn't it?
It has, although interestingly, the source points out that public sector systems like the U.S. Department of Veterans Affairs, VHA, and the Department of Defense, DoD, were actually early adopters and leaders in integrated IT adoption.
Really, ahead of the private sector.
Yes, citing initiatives like the Federal Health Information Exchange, FHIE, and the VHA's VISTI PRS system. They were ahead of the curve long before many private sector systems caught up.
That's a surprising insight, that the public sector was ahead in leveraging IT for quality measurement. It really underscores how foundational data and systems are for driving improvement, doesn't it? Regardless of who is leading the effort.
Absolutely.
What about leadership specifically within academic health centers,
Yeah.
AHCs? These are really complex institutions with their own unique challenges.
They absolutely are. AHCs face a distinct set of pressures, navigating funding uncertainties, addressing health disparities and diversity in patient populations, managing escalating costs, recruiting and retaining top talent, and increasing competition from other healthcare providers. It's a tough environment.
But the source sees a leadership role for them.
Yes, the Academic Health Center source argues that AHCs are uniquely positioned to play a crucial leadership role in the broader shift towards a value-driven health system. They can do this by demonstrating value through their own operational changes, articulating a compelling vision for the future of healthcare, actively shaping health policy through their expertise, and leveraging their vast research capabilities to generate evidence about effective care models and health system design.
But that requires internal change, too.
Definitely. The source stresses the need for significant cultural change within AHCs themselves, particularly in modernizing their educational programs from undergraduate to postgraduate and continuing medical education and fully embracing health informatics as a core discipline. It also discusses the evolving concept of a generalist clinician, no longer expected to know everything, but rather functioning as an amalgamation of specialist opinion within a team.
Right, coordinating expertise.
It's exactly. Which requires deliberately integrated organizational structures that fully include non-physician clinicians, NPCs, like advanced practice nurses or physician associates. And it also highlights the transformative potential of e-health and the internet in revolutionizing knowledge sharing and enabling new forms of patient interaction like virtual consultations, online access to records, etc., despite the challenge posed by competing, often less reliable, commercial health websites.
So AHCs need to leverage their strengths in research and education to lead systemic change, while simultaneously undertaking significant internal cultural and structural reforms to become models of integrated, value-driven care themselves. That's a big ask.
It is a huge undertaking.
Finally, let's focus on clinical leadership. How is this distinct from other forms of healthcare leadership based on the Bishop source?
Well, the Bishop source makes a crucial distinction here. Clinical leaders are explicitly not managers who have become detached from direct patient care. They are individuals deeply rooted in clinical practice. Key characteristics include being visible at the point of care, actively engaging in patient care, being approachable, possessing strong clinical skills and experience, being inspirational role models, and being visibly driven by their core nursing or care values.
So their credibility comes from the front line.
Precisely. Their influence stems from their credibility and expertise gained through direct involvement with patients. The source reintroduces that concept of the ethos gap as the specific tension clinical leaders navigate that pull between their commitment to individual patient care and the demands of management or system-level issues. It proposes congruent leadership as a potential framework, though it's not elaborated in detail in the source that might be better suited to understanding and developing effective clinical leadership than simply applying generic business leadership models directly. It suggests that the unique context of clinical practice requires a tailored approach to leadership theory and development.
That's a vital point, that leadership models might need to be congruent with the specific context of clinical care. Okay. Given all these challenges, strategies, and specific context, how do the sources suggest healthcare organizations should approach developing future leaders? This seems critical.
It's consistently seen as absolutely critical, yes. The Bishop source highlights several areas of need, particularly within nursing. There's a call for better educational preparation for leadership roles, the establishment of robust clinical academic career pathways that recognize and reward expertise and leadership within clinical practice, not just in management.
Right, keeping clinical experts leading clinically.
Exactly. and a need to address the profession's internal diversity and identity issues to ensure leadership reflects the workforce and the patient population. Portfolio development is mentioned as a tool for personal growth, though the source notes that current clinical portfolios are often perceived more as instruments of external control by registration bodies rather than personal development aids.
So the tools exist, but maybe their application and perception need to shift from compliance towards development.
That seems to be the implication, yes.
What else is key for development?
Mentorship is strongly recommended as a mechanism for developing future leaders. It's seen as particularly valuable for fostering emotional intelligence and helping individuals cultivate their own authentic leadership style. The Bishop source touches on the complexities faced by women leaders, who may be judged harshly based on perceived gender stereotypes, whether they exhibit male or female traits. Effective mentorship can help navigate these challenges and build confidence in an individual style.
That sounds incredibly valuable.
And finally, the Leadership Lessons source emphasizes the tactical importance of succession planning. It argues that leaders should ideally begin thinking about and planning for their eventual transition much earlier, perhaps 5 years, before an anticipated departure.
5 years. Wow.
Yes, rather than waiting until age or unforeseen circumstances force the issue, which is often the current reality, that leads to gaps in leadership continuity.
Planning the end from potentially 5 years out, that's a really proactive approach to leadership continuity, isn't it?
It is very strategic.
These strategies and approaches to development offer concrete pathways for building leadership capacity in such a demanding environment. And the sources on mergers even offer a slightly counterintuitive perspective on cultural challenges, don't they?
Yes, that's right. The mergers source notes that while cultural differences between merging organizations are often seen solely as obstacles, they can actually be a source of strength. With open-mindedness and skilled leadership, these differences can potentially be leveraged to create enormous synergy and energy, building a stronger combined entity by drawing on the best of both cultures.
With open-mindedness and skilled leadership, cultural differences in mergers can be leveraged to create enormous synergy and energy. That's a much more optimistic take, isn't it?
It is.
Seeing cultural differences as potential assets rather than just liabilities. I like that. Okay. We've covered a tremendous amount of ground in this deep dive. From historical context and formidable challenges to essential strategies, specific contexts, and crucial development needs. Let's try and consolidate some key insights with a quick lightning round. Prof. Mo Imam, based on everything we've discussed and the sources you've reviewed, if our listeners want to explore one core concept or framework further, what would you point them towards?
I'd say focus on understanding and defining your mission and vision. Both for yourself as a leader and for your team or organization, it really is the bedrock upon which all other leadership actions are built. It gives purpose and direction.
Mission and vision. Okay. What is a common pitfall healthcare leaders should be highly vigilant about avoiding?
Avoiding the temptation to simply apply generic business management models without really considering the unique culture and dynamics of healthcare, especially the specific context of clinical practice and those professional power structures we talked about.
Tailor the approach. Got it. And finally, one simple, actionable step listeners can take today to begin enhancing their leadership journey.
I would suggest starting to practice structured reflective thinking regularly. Set aside dedicated time to honestly assess why things happen, what motivations were at play, yours and others, and what you can genuinely learn from every experience, whether it felt positive or negative at the time.
Brilliant. Clear, actionable advice. Thank you. So to bring together some of the most important takeaways from this deep dive for you, our listener. 1, the fundamental difference between leadership transforming for the future and management maintaining the present is absolutely critical in today's rapidly changing healthcare landscape. You need both, but leadership drives necessary change. 2, effective leadership has to acknowledge and actively address the unique historical, cultural, and systemic challenges embedded within healthcare. Things like historical power imbalances, burnout, policy influence hurdles. They're real and need tackling.
Definitely.
3, core strategies for success include having that clear vision and mission, building genuine commitment and trust, mastering effective communication, and understanding the power of empowerment and rewarding desired behavior.
Livers.
4, leadership isn't one size fits all. It manifests differently in specific contexts like lean practice, quality improvement efforts, academic health centers, and frontline clinical care. Each requires tailored approaches.
Context matters.
And 5, Developing future leaders is essential. It requires focus on better education, diverse career pathways, mentorship, and proactive succession planning, alongside that commitment to continuous self-development through reflection. Prof. Imam, thank you so much for guiding us through this wealth of information and distilling such valuable insights. It's been incredibly helpful.
My pleasure entirely. It's been a really insightful discussion. I've enjoyed it.
Good. If you found this deep dive valuable, please do consider rating and sharing the show so others can discover these insights too. And as we wrap up this deep dive into healthcare leadership, here is a final provocative thought drawn from the source material for you to consider. Given the profound challenges and the immense potential for transformation, perhaps the healthcare professions themselves, through the leaders they cultivate, or indeed fail to cultivate, ultimately get the future healthcare system they deserve. Something to think about. Until next time.